So the patient I had today was a 79-year-old, 56-kilo patient. Just a little lady. She was 157 centimeters tall and had a diagnosis of colon cancer and right adenocarcinoma. Her surgery planned for that day was a laparoscopic-assisted right hemicolectomy. She had a fairly extensive medical history of angina, hypertension, COPD, asthma, and osteoarthritis to C5 and C6. She had a pulmonary function test back in July 2020 that showed moderate to severe COPD, and she's also had an echo that showed an ejection fraction of 55%. Her at-home meds include diltiazem, nitroglycerin patch and spray. She also takes prednisone, montelukast, and salbutamol for her COPD. Her airway looked good. It was a Mallampati of 1. She only had 3 of her own teeth, otherwise no dentures or anything like that. And had a good mouth opening, good thyromental distance, and had full mobility of her neck. Some considerations when doing anesthesia on patients with these characteristics. With her advanced age, her anesthetic needs are going to be way down, especially in regards to her propofol, and with gases, her MAC will also be decreased. Her history of angina and hypertension, as well as her advanced age, put her at risk of post-induction hypotension, as well as just intraoperative hypotension. So to prepare for that, we'll have emergency drugs ready, such as phenylephrine, a pump ready in case she needs an infusion, as well as an art line just to have beat-to-beat blood pressure measurements. COPD will put the patient at increased risk of intraop hypoxemia, as well as it could cause an issue with post-operative pain control since the opioids will affect her respiratory drive. With her age and an expected operation time of almost 3 hours, she will be put on DVT prophylaxis, so 500 milligrams of heparin, as well as with a colon surgery, she should be on an anaerobic antibiotic for prophylaxis, so she can have Flagyl for that. She also has a bunch of risk factors for post-operative nausea and vomiting. She's female, a smoker, and she's expected to get post-operative opioids. So to combat the post-operative nausea and vomiting, she can get dexamethasone during the surgery and ondansetron at the end of the surgery. Following the protocol that they follow, enhanced recovery after surgery, so ERAS protocol, she should be on a lidocaine infusion. Fluid-wise, not super concerned, probably just like gravity dependent, but will avoid fluid overload, especially with her respiratory and cardiac history. And since it's a laparoscopic procedure, they'll be filling the belly with CO2. So it's a good idea to hyperventilate at the start to blow off some CO2, because there'll be some absorption, so you can expect that to increase. So monitor-wise, when she enters the room, she'll have an art line put in, an IV, blood pressure cuff, ECG leads, SAP probes. She'll have the train of 4 on. And then for induction, will receive 50 milligrams of propofol, so that's just under 1 per kilo, just to try and avoid that initial hypotension, and as well as she'll have the decreased needs due to her age. 40 micrograms of remifentanil and 50 milligrams of rocuronium. Once intubated, and she's expected to have an easy intubation, but she was a little bit difficult to bag due to not having teeth. So she kind of lost that structure. So it was hard to hold up her cheek up against the mask. Once intubated, confirmed with end tidal, and she was put on sevoflurane, targeting MAC of 1. So she has decreased needs. So she will need less than that 2%. And during the surgery, as discussed before, can expect hypotension, pump ready for phenylephrine. And we did end up having to use that just for the first 5 minutes or so post-induction. And then she actually was pretty steady for her blood pressure. Hydromorph and remifentanil top-ups were used, a lidocaine infusion of 1.5 milligrams per kilogram per hour as per the ERAS protocol, and antiemetics like dexamethasone and ondansetron were given, as well as the antibiotics and the DVT prophylaxis. At the end, we reversed her with neostigmine because she needed some rock top-ups just when they were trying to close her. And post-operative pain control, she can be ordered to have Tylenol as needed, as well as 1 to 4 milligrams of morphine IV every 5 minutes with a max of 10 milligrams. Otherwise, fluid-wise, she did well. She used got 1 liter of fluid and had minimal blood loss, only 100 to 150 cc's. She woke up well, wasn't in pain, and was sent to PACU.